Hi, my name is Abby Connerly. I'm a nurse practitioner at the Arkansas Heart Hospital and Clinic. I work specifically with Dr. Monica Lowe in the subspecialty of electrophysiology. Today, I'll be talking about syncope, grayouts versus blackouts, and how we work this up. So let's first talk about what is syncope. Syncope is a decreased cerebral blood flow causing one sudden loss of consciousness and sudden loss of postural tone. It is associated with a spontaneous recovery. In one's life, it will occur in about 3% of men and 3.5% of women. This risk does increase with age. It can occur suddenly versus with a prodrome. A prodrome would be nausea, diaphoresis, tunneled vision, and this is most likely associated with vasovagal syncope. What is not syncope? This would be vertigo, seizures, pseudo-seizures, hypoglycemia. It could be drug-induced, alcohol, or trauma. There are subgroups of syncope, including neurally mediated, orthostatic, neurologic, and today I'll be focusing on cardiovascular syncope. This type of syncope is associated with the highest risk of mortality out of all of the subgroups. It has a 50% rate of mortality over 5 years. So specifically looking at patients with genetic disorders such as Holcomb's, cardiomyopathy, or long QT syndrome, it's important with these patients to rule out sudden cardiac death risk. This workup is a lot of times done in hospitalized patients as they typically are higher risk patients, multiple comorbidities. So what we're looking at here is an obstruction of cardiac output and a disturbance of cardiac rhythm. So for the obstructive type, this could be a valve problem, so aortic or mitral stenosis, Holcomb's cardiomyopathy, atrial myxoma, pulmonary embolism, pulmonary hypertension, and less commonly would be cardiac tamponade. With obstructive syncope, we've got, this occurs either with exertion or shortly after exertion. For the arrhythmic causes of syncope, we've got sinoatrial disease, sick sinus syndrome, AV block, SVT, VT, pacemaker disorders. So here's a flow sheet just looking at how arrhythmic causes of syncope work. So we have extreme rates, either high or low, which causes a decrease in cardiac output, hypotension, cerebral hypoperfusion, and then your syncopal episode. So now I'll go into the different subgroups. So sick sinus syndrome, persistent or episodic sinus bradycardia, tachybrady syndrome. So this would be a patient with AFib RVR with a conversion to normal sinus rhythm, long sinus pause. High degree AV block, so disease of the AV node, junctional rhythm, narrow QRS, disease of His-Purkinje, wide complex idioventricular rhythm, bifascicular block with long PR, ventricular tachycardia. So this is the most common cause of syncope. It can be associated with structural heart disease, previous MIs, depressed EF, non-ischemic cardiomyopathy, or normal LV function patients. Torsade de points. This is associated with congenital long QT syndrome, acquired long QT syndrome. So with these patients, it's important to ask the right questions. Elderly patients immediately assume upright posture. So for our case study, we have a 70-year-old man with CAD and EF of 45% presented after driving into a ditch due to syncope. I feel like I might have syncope right now. I'm so sorry. His blood pressure was normal, heart rate was normal, CT of the head looked okay, carotid ultrasound revealed a left carotid stenosis of 80%. He actually had a CEA done during his hospital stay, and he had an SCA that showed patent stents. It did show some non-obstructive disease, but no intervention was needed. So what do we do next with this guy? At discharge, would you send him home with an event monitor, refer to neuro, refer to EP, provide reassurance since he had the CEA done, or order a life vest? So for this particular patient, we did end up sending him with an event monitor, and he ended up having this. So this kind of drives home the point why it's important with syncope patients to do a full workup, because actually arrhythmic causes of syncope are pretty common, and for this guy, clearly putting a monitor on him could have saved his life. So he did get a defibrillator for secondary prevention, and he did really well. So I actually am going to go back and again apologize. So I'll just kind of go back into the different arrhythmias that can cause this. So I did talk on this one a little bit. With sick sinus syndrome, it can be something that they deal with intermittently. So it can be hard to catch in some. And for our elderly patients especially, it's important to get them seen and have them on a monitor. They may need a pacemaker for this. For the high degree AV block, so I did want to touch on this. It's the disease of the AV node with a junctional rhythm, narrow QRS, is less dangerous than a disease of the his Purkinje. So if you get below the his Purkinje, we have a wider QRS, which is more associated with poor outcomes. So this is definitely the scarier of the two. Either way, you would be looking at possibly putting a pacemaker in these folks. So for VT, of course, this, like I said, was the most common. For structural heart disease, previous MI, a decreased ejection fraction, non-ischemic cardiomyopathy can be a cause. With those with a normal LV function, it would be more likely to be someone with a genetic disorder, like long QT syndrome, ARVC, or Brugada syndrome. Torsade de pointes. I did want to touch on this too. So it can be caused from a congenital long QT syndrome. In this case, the torsades could be intermittent, or an acquired long QT. So then we're looking specifically at a few things here. One being antiarrhythmic drugs. I think everyone can agree on that. So with our class 3 agents, this would be Sotalol or Ticastin. We do bring them in the hospital to get loaded on these, partially because of the risk of torsades. Also electrolyte disorders, so looking at the magnesium, potassium, that could potentially be an easy fix where we could avoid torsades. R on T, this is meaning R on T pacing, so a pacemaker or defibrillator paces. This way it can lead to torsades. And then also an unsynchronized cardioversion could lead to torsades. For medications, other than antiarrhythmics, we're looking at specific antibiotics. So fluoroquinolones can be a cause of this. SSRIs, antidepressants like SSRIs or tricyclic antidepressants. Some antihistamines can be a cause of this. Some nausea medications like Zofran can also widen the QT interval. So with the whole point of this is, I think personally the H&P is one of the most important parts in this. So we want to ask the right questions, because by asking the right questions, we can know where to go with our workup. So for an elderly patient, this is just kind of some examples of the different situations. So an elderly patient immediately stands up, they feel dizzy, lightheaded, fall, orthostatic hypotension. Elderly patients with an abrupt loss of consciousness, they just go out, no warning. This is more associated with sick sinus syndrome or a high degree AV block. For our young patient, such as myself, with a normal heart, prolonged standing, after a lab draw, a hot shower, standing up in front of a group, that's more neurocardiogenic syncope. So syncope while shaving or turning to one side would be carotid hypersensitivity. So for our diagnostic testing, the initial workup can usually be done in a primary care setting. So we're looking at labs, CBC, serum electrolytes, and EKG isn't usually a high yield for syncope, but it can also be helpful in ruling out different things. An echocardiogram, of course, would be a good example for obstructive disease, ruling out any kind of valvular issue. An ischemic eval, so we're looking at the patient's personal history as well as family history with this. Would they benefit from a stress test or maybe even a heart cath? A treadmill stress test can be particularly helpful because it can see both the ischemic cause for it as well as arrhythmias associated with exercise. So if they get referred to EP, of course, we're going to want to put them on a monitor, the longer the better for that, so we can catch the arrhythmia. A head-up tilt table test is helpful in diagnosing neurocardiogenic syncope or POTS. An implanted loop recorder is helpful in those that are having infrequent episodes, so they've had a workup, we're having trouble figuring out what's causing their syncope. This is a simple outpatient procedure we can do for that. For our high-risk patients, of course, an EP study could be helpful, especially for tachyarrhythmias like SVT or VTAC. Went over that. And again, my name is Abby Connerly. I do work with Dr. Monica Lowe in the specialty of electrophysiology. We're always happy to take referrals. And if y'all have any questions, please don't hesitate to reach out to me. Thank you.